Hello everyone, a warm welcome from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy. I would like to acknowledge the traditional owners of the land, so the Ngunnawal and the Ngambri people. I acknowledge that this is the land that belongs to them, and this is the land where we at ANU are located and where we are broadcasting to you from. I would like to pay my respects to their elders, past, present, and emerging. I would also like to welcome all of our attendees. We have attendees from various parts of the world, ranging from India, Australia, China, Burma, Indonesia, just to name a few. Now, we know that knowledge is power, so we hope that through our weekly webinar series, it will help us to share and learn from each other's experience and expertise during this pandemic. Today, we are delighted to have 4 astounding speakers, all with incredible knowledge and experience in dealing with the neonatal population. And they are going to discuss COVID-19 in the neonatal population, how we can manage these patients. Before I go on to introduce our speakers, I would like to introduce myself and my team. I am Evangeline. I am one of the medical students and a volunteer for the ANU COVID-19 Peer Support Program. And joining me are my colleagues. We've got Devashi, who is another student volunteer, Bridget, who is another student volunteer, and Associate Professor Dr. Dipti Talalika, who is a hematologist and a director lead for this peer support program. Before going on to introduce our speakers, I just want to share a couple of housekeeping notes. Number one, I would ask for all attendees to have their video and microphones switched off. This is just to help us make sure the sound quality is clear and will help reduce any interference with the webinar. I would also encourage all of our attendees to ask questions, and you can do so at any point during the talk. Simply look at the bottom of your screen. There you can see a Q&A button. You can submit your questions from there. If you do not wish to be identified, there is an option of submitting your questions anonymously. Now, towards the end of the presentation, we will also be launching a poll, and I would invite all of our audience to please submit a response. This will help us to collect some feedback. And if you have any technical issues or questions after the talk, I would invite you to email us and we will try our best to assist you. I can share our email address towards the end of this session. And finally, please note that this forum is being recorded. So on to the webinar itself. Today, we have a webinar delivered by four speakers. So many of us have seen Dr. Satish Ganda in our previous talk. He's a neonatologist and intensivist and also a developmental pediatrician. He will share some insights into how COVID-19 was managed during the Delta wave pandemic in India in neonates. And joining him will be Professor Abdul Latif Mohammed. And we also have 2 other panelists, which are Dr. Anil Gupta and Dr. Sankeet Yelineti. So I'm very excited to hear your talk, and I'll pass my time to Professor Mohammed.
All right, thank you very much, Evangeline. I would like actually just to start by thanking the organizing committee for this talk, Professor Dipti, Evangeline, Devashi, and Bridget for your hard work. Thank you very much. As Evangeline mentioned, I have my colleagues. I have my colleague Satish, Dr. Anil, as Dr. Sankeet from India. So they are going to do the heavy lifting and they are going to share their experience in managing COVID cases, and we are going to focus on neonatal cases. I'm going to start by giving an introduction, just general introduction about neonatal COVID and some definitions, and then I will hand over to Satish. And Satish will introduce how is the rest of the talk going to be divided. But basically, we will go through some statistics for the COVID cases, neonatal COVID, focusing on neonatal, from the first wave and second wave in India, in Hyderabad. And then after that, we'll go through some interesting cases, which is all will be done by Satish, Anil, and Keith. So without ado, I'll go to the presentation. So the incidence is very variable, and that's depend on different regions in the world. Obviously, there is many cases reported in India in the recent outbreak. Similarly was in Europe and in US. But overall, the estimated incidence in newborn is estimated to be between 0.1 to 2% of infant born to mothers who test positive near the time of delivery. Similar to other infections in the neonatal period, there is three modes of transmission for neonatal COVID: intrauterine transmission, intrapartum, and postpartum transmission. So I'm going to go through all of these three modes very quickly. Intrauterine transmission is not very common. And this similar, as I said, to other neonatal infections. It can be hematogenous, spread through the placenta, or can be through the amniotic fluid if there is any particles of the virus or virus in the amniotic fluid, and through inhalation of that amniotic fluid that can infect the fetus. The second mode of transmission is intrapartum transmission, and again, similar to other infection, and this is just exposure of the infant during the delivery process to the secretions of the mother. And this can be through blood or other secretions from the mother. And the third mode of transmission, which is the most important and by far the most common mode of transmission, is transmission either from an infected mother or family member or even a healthcare worker. And this is the most common mode of transmission. The role of breast milk is not very well established, but we think that if at all it contributes, it's very minimum contribution. There is, generally speaking, there is three presentation for neonatal COVID. And again, this is very similar to the other infections in neonate. We divide it into early onset neonatal COVID and late onset neonatal COVID. And we have a third category here, which is multi-system inflammatory syndrome. So I'm going to go through this very quickly. The first one is the early onset, and that's onset of neonatal COVID within or before the 7th day of life. And then late is beyond 7 days. So among the early onset neonatal COVID, as you can see from the slide, again, the incidence, the numbers differ by region and by case series you look at. But generally speaking, around 40% will have very severe symptoms, and that can reach up to ventilation. In terms of late onset is even more, maybe up to 80% will develop some severe symptoms. Neonatal MIS-C or multi-system inflammatory syndrome is not very well characterized in neonate compared to pediatrics, but later on Satish is going to talk about his experience about neonatal MIS-C and also show us some of the cases and how they present and how they were managed. So the early onset neonatal COVID, as I mentioned, again, the presentation typically is before 7 days, and this can range from just temperature instability to some respiratory symptoms. And as I mentioned earlier, around 40% of infants who present like this will have severe illness. Second clinical presentation is late onset, and this is often more serious. And up to 80% of infants, depending on which series you look at, will present with very severe signs and symptoms, and thus can reach up to ventilation. Again, similarly, there is temperature instability, respiratory distress, and some other features. Third presentation, and often this can happen later on, is the neonatal MIS-C or multi-system inflammatory syndrome. And this can be very serious, and it presents with multiple clinical features, including myocarditis, including DIC, obviously ventilation and respiratory distress, etc. And as I said, later on, Satish is going to talk about this in a bit of detail and share some of the cases which have been managed with Satish and his team in India. So I guess I will hand over to Satish to continue here about the rest of the presentation and the experience from India. Satish, all yours.
Thank you, Latif. And at the outset, I'd like to thank Dr. Deepthi Devashi, Evangeline, and the whole team, Bridget, who've taken lots of efforts to make this happen, to liaise with everyone, with the sole aim of sharing knowledge, as she rightly started out with. So we'd like to share the knowledge, whatever we've gained from this situation where we as a team have been forced to manage these children. So hopefully from this discussion that we have, hopefully we'll be able to share our thoughts, and then we all could manage our children in a much, much better way. So in this webinar, we would like to share our COVID management experience and statistics in the neonatal population during the first and second wave in the city of Hyderabad in India. So we'll classify it into the neonatal COVID and the multi-system hyperinflammatory syndrome in the neonates. And then we'll start off by having interesting case presentations. And then at the end, we'll have a COVID and MIS-C management algorithm for both the conditions, and then certainly a take-home message. So where we are or where we come from, basically it's a twin cities called Hyderabad and Secunderabad. We are almost located in the central part of India. The population is about 10.25 million, which is a little less than half the population of Australia. And this is the 6th most populous city in India. And predominantly the healthcare is both public as well as private. So in the twin cities, we have about 50 government hospitals, but the big hospital that actually takes care of the children is called Gandhi Hospital. And we do have lots of private hospitals who sort of take care of these kind of children as well. So I'm from one of the private hospital called Little Stars Children's Hospital. So this is where our data has come from. And whatever our data is, it seems to resonate well with the other centers across the country. So I hope it'll give you a good snapshot about how the caseload as well as the way the children have been presenting across the country, across India as well. So I'd like Dr. Sankeet to speak right now. So maybe if he could unmute himself, Dr. Sankeet.
Good evening, everyone. We would like to discuss our unit's experience in the management of neonates admitted to our unit with COVID-associated illness. In our unit, we have managed around 24 neonates, whom we have briefly categorized into 3 groups. The first group being clinical COVID-19. These are the neonates who were born to COVID-positive mothers and have deliveries attended by our team members, and the immediate newborn care has been provided by us. Of them, we found 5 neonates who were completely asymptomatic and received only routine newborn care. And we have around 6 neonates who had mild symptoms, whose symptoms I wouldn't label it and say this is because of COVID illness, but that course of the neonatal illness is consistent with the normal condition which we expect in the neonatal period. We had another group where children who presented to us in the 3rd or 4th week of life with acute COVID-19 illness, RT-PCR testing positive, maybe in the perinatal or postpartum acquisition of infection. We have divided these into 2 groups. Of them, 4 presented in a critically ill stage with multi-system involvement and multi-system derangement, and 1 child who presented with an obstructed inguinal hernia. So I had another group, which is a new terminology and evidence coming up by day, that is multi-system inflammatory syndrome in the neonates. So this is a term, multi-system inflammatory syndrome in neonates, which we are hearing a lot after the similar presentation seen in children. In these, we have seen around 8 children, of whom 5 they are confirmed to have neonatal MIS-C. As you know, there's no fixed criteria for diagnosis of neonatal MIS-C, multi-system inflammatory syndrome, but we have adopted our inclusion criteria from a similar study done by a unit in India who have managed around 20 neonates with presumptive diagnosis of neonatal multisystem inflammatory. So we have around 5 confirmed cases and 3 cases being probable. That's because of multiple reasons, which we are going to discuss in our case presentation further. So in our experience, in the first group, there are around 11 neonates who were born to COVID-positive mothers, 5 being asymptomatic, 6 with mild symptoms, 3 had early onset sepsis, managed accordingly, and 5 needed non-invasive respiratory support for respective indications of mild respiratory distress syndrome or transient tachypnea of newborn. The mean duration of stay in this group was calculated as 3.81 plus or minus 2.3 days, and all the babies have been discharged in a healthy state. And multi-system involvement was seen in none of them, and mean of all the inflammatory markers at CRP, ferritin, LDH, D-dimer, IL-6 were normal. So in the next group, who actually came to us in a critically ill stage, 4 of 5 presented to us in a critically ill stage, 1 child with an obstructed inguinal hernia needing closure, and 4 of them required invasive respiratory support. The mean hospital stay was recorded as 26.8 plus or minus 13.31 days. Dexamethasone use was used in 3 patients for a duration of 5 days. This was extrapolated from the data which we had in the pediatric population. And multi-system involvement was seen in all the 4 critically ill children. 1 child had meningitis, 3 of them presented with severe acidosis, and mean CRP and mean IL-6 were elevated in this group. And an outcome, that's the good part, all of them have improved and discharged healthy after a stormy neonatal course. There's no mortality described, and as we were discussing, there's no fixed criteria for diagnosis of neonatal MIS-C. So this is the criteria we have adapted from a similar study done in Maharashtra, where they have managed around 20 neonates with a presentation similar to multisystem inflammatory syndrome. Of them, the criteria being neonate that's age less than 28 days, severe illness needing hospitalization, maternal history of COVID illness or exposure, positive antibodies detected against COVID-19 detected in the baby, and laboratory evidence of inflammation or elevated levels of one or more of the following: CRP, D-dimer, ferritin, fibrinogen, IL-6, and pro-BNP. And obviously, there should be no alternative diagnosis. So the children diagnosis were excluded, like birth asphyxia or a culture-proven sepsis, or the neonatal course is consistent with the normal neonatal disease course. So in our unit, we had a investigation protocol. All the babies underwent testing for complete blood picture, kidney function test, liver function test, echocardiographic evaluation, and quantitative ELISA antibodies for COVID. And all the inflammatory markers which we discussed have been estimated for these babies, including C-reactive protein, ferritin, LDH, D-dimer, fibrinogen, pro-BNP, IL-6, and troponin I. So coming to the treatment protocol which we followed, treatment was tailored as per assessment of baby on an individual basis. Most of the times for every child, as we had to discuss with multiple neonatologists all over the country in a best intention not to harm the baby with the treatment, because we don't treatment should not be harmful than the disease. So that's the reason multiple discussions have occurred among the neonatologists to tailor the plan for each newborn. We have treated sick babies who did not respond well to regular treatment protocols as per expected neonatal course. IVIG was given to 3 babies at 2 gram per kg, and steroids were given to 2 children out of 5. Methylprednisolone 1 mg per kg for 4 days, followed by prednisolone for 10 days. Aspirin or anticoagulation were not given for any of the babies, with obvious risk of intraventricular bleed and no evidence of safety in the neonatal population. So in our unit, with neonates presenting with MIS-N, we have 5 confirmed and 3 probable cases. 3 were critically ill. Unlike the usual presentations of cardiac issues in multiple case reports mentioned, we had 2 children presenting with an encephalopathy-like presentation, which we're going to discuss in the coming slides, and 2 children with upper airway issues, and 1 child with cardiac issues. The hospital duration was around 20.25 plus or minus 16.7 days in this group. The good thing is all the babies have been discharged healthy. So this is a brief cases of brief description of all the cases of neonatal MIS-C which we have seen. You can go through once the discussion has been kept in the. I would like Dr. Anil Gupta to take on with the presentation for interesting cases which we have managed.
Good evening, everyone. I will be presenting two cases of acute COVID in neonate. Case 1 is a 31 days old preterm 29-weeker baby with birth weight of 1.18 kg. At birth, baby had respiratory distress syndrome, required 1 dose of surfactant, followed by mechanical ventilation for 1 day, non-invasive ventilation for 5 days, and oxygen for 2 days. Baby was discharged on date of life 25 at corrected gestation of 33 weeks with a weight of 1.4 kg. This baby was readmitted 2 days later with complaints of lethargy, overfeeding, and respiratory distress. At admission to the ER, the child was in respiratory failure, requiring intubation and mechanical ventilation. Chest X-ray showed bilateral areas of atelectasis and hyperinflation. Blood investigation showed raised septic parameters, started on IV antibiotics. Same time, RT-PCR for COVID-19 was positive. This baby was referred to our unit on day of life 31 in view of COVID pneumonia. At admission to our unit, this child was continued on SI mode ventilation, later needing high frequency oscillation in view of increasing ventilator requirement and hypoxia on conventional ventilation. Blood gas revealed mixed acidosis. Chest X-ray showed bilateral hyperinflation with atelectasis and right upper lobe collapse. Blood investigation revealed raised total leukocyte count and raised CRP. Blood culture was sterile. Other inflammatory parameters, D-dimers and IL-6 was also significantly elevated. 2D-CO was normal. This baby was started on IV antibiotics. Injection dexamethasone was started at the dose of 0.15 mg per kg per day for 5 days in view of COVID pneumonia needing mechanical ventilation. Baby had persistent right upper collapse despite physiotherapy, nebulizations, and needing respiratory support, high flow nasal cannula. So we had to perform flexible bronchoscopy on day of admission 10, which revealed mucus plug, which was cleared, and bile culture grew Acinetobacter, needed antibiotic upgradation. But this baby again needed bronchoscopy because of persistent right upper lobe collapse and high flow nasal cannula. This repeat bronchoscopy revealed right upper lobe fibrosis. Eventually, high flow nasal cannula was weaned to nasal oxygen and X-ray was more looking like chronic lung disease. So this baby was discharged on home oxygen. Coming to the second case, this is a 30 days old baby, term 2.7 kg, born to primary mother with uneventful postnatal period. This baby was admitted at day of life 15 for 5 days in view of hypernatremic dehydration, had sodium of 180 and weight loss of 25%. This baby had one episode of seizure and blood parameters, septic skin was negative, treated with IV fluid and IV antibiotics. This child was well for almost 15 days, again readmitted at day of life 30 with history of fever and lethargy for 3 days, had 4 episodes of seizures. Blood investigation revealed raised CRP and total leukocyte count. Blood culture was sterile, treated with oxygen, IV antibiotics, and antiepileptics. This baby was referred to our unit in view of COVID RT-PCR was positive. At admission to our unit, this child had dull sensorium, having respiratory distress, and blood investigation revealed raised total leukocyte count with predominantly polymorphic, 80% are polymorphs, CRP of 58 milligram per liter, procalcitonin was significantly elevated, 34 nanogram per ml. We performed lumbar puncture with suspicion of meningitis, which showed 162 cells, mostly polymorphic with low sugar and raised protein. Other inflammatory parameters like serum ferritin, fibrinogen, and D-dimers were also significantly elevated. Blood culture for this baby was sterile, and later CSF culture grew E. coli. At admission, this chest X-ray was almost near to normal. We did CT chest because child was needing high flow nasal cannula, having respiratory distress, and X-ray was near to normal, which showed ground glass haze in posterior part of both lungs, which was consistent with cohort stage 4 COVID pneumonia. This MRI brain was done, which showed bilateral ventricular enlargement and ventriculitis. This baby was treated with high flow nasal cannula, IV antibiotics, IV antiepileptics, and we started IV dexamethasone in view of COVID pneumonia and baby needing respiratory support. This baby also needed reservoir placement followed by VP shunt in view of worsening of hydrocephalus. Both these cases are neonate. One is preterm babies, another term baby. Both had COVID pneumonia with respiratory distress needing respiratory support. One baby needed high flow nasal cannula, another baby needed mechanical ventilation. Both were treated with steroid for 5 days, and anticoagulation were not given because there was not much evidence despite raised D-dimers levels.
Thank you, Dr. Anil and Sankit, and Dr. Latif as well. So that was a brief about 2 children who've been managed with us. So what I'd like to go is, I'd like to enumerate 2 more cases who have presented in a very different way. So first is baby of Lavanya. This is a full-term baby, 2.5 kilos, born on 22nd of April at 11 a.m., cried at birth, with good upcards and breastfed on day 1. On day 2, the baby was hyperalert and irritable, and a video at 4 hours prior to admission showed that the child had seizures. Was referred to Little Stars ER at 45 hours of age, with history of dull activity and poor feeding. On examination, this baby was unresponsive, peripherally cyanotic, hypoglycemic up to 26, had dextrose and normal saline boluses given, and at 8:30 had seizures, pretty much like a staring look, shrill cry with bradycardia. Midazolam was given and later loaded with Levipil. That was the first anti-epileptic drug. This child continued to have persistent poor sensorium with multifocal clonic seizures. And again at 12:30 and 3 p.m., this child continued to have seizures, so was loaded again with phenobarbital and calcium as well. By 6 p.m., the child was on the 3rd and the 4th anti-epileptic drug, that is both phenytoin as well as midazolam infusion. So this child had to be intubated and ventilated to support the airway. MRI on day 1 of admission showed a diffusion weighted imaging restriction involving the parietal and the occipital cortex, which made us think, was this because of hypoglycemic insult? But the blood results which were done, there was no evidence of sepsis. Blood cultures were normal. There was no growth. CSF analysis on day 2 was absolutely normal. There was no evidence of meningitis. Culture sensitivity showed no growth. EEG was bang normal, and the 2D echo was normal as well. The only thing of note was this bilirubin, which was 22, but that was again indirect hyperbilirubinemia. And the CSF analysis is there for you to see, which is pretty much normal. So the diagnostic possibilities, first is persistent seizures and neonatal encephalopathy. We weren't sure about the cause. MRI showed DWI restriction involving the parieto-occipital cortex, as I've said, could be because of hypoglycemia. Sepsis and meningoencephalitis was ruled out for the bloods that you've seen, and just the bilirubin being high. So on day 3 and day 4, then when we sat with the parents again, we took a history, and then the parents did say that the maternal family was completely COVID positive somewhere in the 7th or the 8th month of pregnancy. So these were the SARS CoV-2 antibodies on the baby, and that's the total, and the IgG antibodies as well. So both the mother, the father, and the child, all of them have had highly elevated markers. As soon as we've got these results positive, the COVID inflammatory markers were done. They were also elevated. The IL-6 was 23 and pro-BNP was 4057. So on day 4, when we had these results on hand, this child continued to be sick on the ventilator. So that's when we've decided, yes, this child could be fitting into MIS-C, and we've given 2 grams per kilo of IV immunoglobulins and methylprednisolone 2 milligrams per kg per dose per day for 3 days, and then the steroids were tapered. So these were the investigations timeline. If you see the with the advent or the once the IVIG and the steroids were given, the pro-BNP, as you can see, has nicely come down from 4057 to 3100 to down to 1249, and the trends have been certainly better. Regarding the ventilation, this child was extubated on day 5 to HFNC, but we were not able to get this child back onto nasal prong oxygen. The child needed the little bit of a support with the HFNC. And then we've got a chest X-ray done, which suggested of a CORAD-3 or a COVID lung, which wasn't very, very characteristic, but there were some doubts that this could be a COVID lung. Then on day 7, the child was on nasal prong oxygen, and the child was discharged on home nasal prong in view of the chronic lung disease. And that's the baby on home oxygen. And this is the baby at 4.5 months. This picture was taken a week ago, where the baby was developmentally appropriate on follow-up. Now, the next child is a child, baby of Srilata. Is a 14-day-old boy who was brought to the emergency room on this 26th of May this year. Weight was 2.7 with complaints of high-grade fever, 1 day continuous associated with loose stools and vomiting, dull activity, and reduced oral intake. The rapid antigen test was positive, was brought here, and we have done the RT-PCR, which was also positive. Child was pale, sick-looking, dehydrated with poor perfusion, loose stools and fever persisted. There's a gross metabolic acidosis with pH of 7.15 and a base deficit of -17. Bicarb was only 11. So this child received oxygen, fluid resuscitation, inotropes as well. So these were the this was the admission diagnosis in the COVID ICU. We have a child with severe sepsis and septic shock, acute gastroenteritis with severe dehydration and acidosis, and as I said, a RAT and a RT-PCR positive in this child as well. So this child, as I said, oxygen, inotropes, triple antibiotics. At 12 hours, the child continued to be dull, lethargic, and sick with poor perfusion. The RD persisted, so escalated to HFNC. And these were the bloods which were unremarkable. And on day 2, the following day, the child continued to deteriorate further, persistent metabolic acidosis on inotropes, that's dobutamine and adrenaline. Pentaglobulin were given in view of the severe sepsis, intubated and ventilated as well. And taking the acute COVID into consideration, this child was given 2 milligrams per kg per day for 3 days of methylprednisolone as well. The 2-day echo showed 55% ejection fraction in a structurally normal heart. CSF was normal. Abdominal distension was quite significant. X-ray showed gaseous bowel loops. So on day 3, the child had red currant jelly stools. Our DD at that point in time was necrotizing enterocolitis, NEC or enterocolitis, because the child had abdominal distension, tenderness, and guarding and rigidity as well. So an explanatory laparotomy was done, and what we found was gangrenous bowel segment with impending perforation in the mid-ileal region. So a resection was done and an ileostomy was performed. Post-op, the child was fine. On TPN, hemodynamics have been stabilized, acidosis resolved, and bowel movements were restored in 48 hours. So that's the baby on the vent in the post-op COVID ICU. And that's the dead bowel, which you can see in that bottle. So this child had non-oliguric AKI, which was noted, dyselectrolemia, which was managed. Repeat COVID markers showed a decreasing trend, both the ferritin, D-dimers, and the fibrinogen. Child was extubated to HFNC on day 8. And on day 10, the COVID RT-PCR was negative, was shifted to the non-COVID ICU. Weaned to oxygen on day 11. Oral feeds were tolerated well. And the child, this was the biopsy report of the resected bowel. It showed mucosal ischemic necrosis with exudate consistent with gangrene and necrotizing enteritis. And the pathologist did feel that the neonatal NEC has been reported in COVID as well. So the parents were trained for ileostomy care. Ultrasound was normal and the child was discharged on the 12th. Now, unfortunately, this child came back on the 15th of June, day of life 34 with fever, loose stools, poor intake for 2 days. And at admission, the child was sick looking, irritable. Some dehydration was there, but the ileostomy was healthy. So the differential diagnosis is something else. It's not an ileostomy infection. So it could be acute gastroenteritis or sepsis, feed intolerance, and we did malabsorption workup as well. And the child was given fluids, IV medications, and triple antibiotics. And if you can see, that was the trend of CRP, which was normal at discharge. It rose up to 67 now. Even the ferritin was elevated at 979, and IL-6 was 457. Very high, very much elevated. And that you can see the trend with the next numbers as well. So on day 4, as part of the workup, COVID ELISA antibodies were done, which were positive. And as I said, the numbers were quite evident as well. IL-6 was 457. So in view of this persisting ongoing fever on day 5, failure to gain weight despite feeds, fluids, and no signs of improvement despite all the other measures. That's when we finally thought, yes, this is MIS-C, given the evidence with the antibodies as well as the inflammatory markers. So we've given 2 grams per kilo of IV immunoglobulins and methylprednisolone 2 milligrams per kg per day, and aspirin was given as well. So the baby later showed significant improvement clinically and discharged on day 11 on 26th of June this year. And the parents were counseled regarding the feeds and ileostomy care, and the baby was discharged. So that is just before discharge with the ileostomy. And this is last week. This is the child doing quite well on follow-up 4 months. So this is the only reported case of, as I said, a 15-day-old COVID positive neonate presenting with sepsis, DIC, MOD, acidosis, and an ischemic gut which had to be resected, and was readmitted again with a classical MIS-C. So one child had a double whammy, both the infections present, but this child is better now. Now, this is another child, baby of Pratima. This is the child who's doing very well now, born to a critically ill mother at 33 weeks gestation, had NIV support, COVID-induced tachyarrhythmia was there at 12 hours on day 2 and day 4, is doing well on propranolol 0.1 mg per kg right now. COVID antibodies were positive. And as I said, unfortunately, this mother was on the ventilatory support and actually succumbed on the same day the baby was born. But the baby is doing well now. So this is another child with spontaneous ileal perforation, born to a critically ill COVID positive mother on NIV support with oligohydramnios and an absent end-diastolic flow. Emergency LSCS at 31 weeks because of IUGR, and the child had RDS, surfactant was given, ventilated. On day 2 had abdominal distension. The child was nil by mouth, had TPN being given. On day 3 had a pneumoperitoneum. Emergency lap was done. Terminal ileal perforation with necrosis of the wall and meconium in the peritoneum was noted, and an ileostomy was done. And biopsy showed necrotic areas with intact myenteric plexus. Those are the numbers, and that's the peroperative picture for you. Now, this is the next child, baby of Saujanya, who has had COVID fingers. So antenatally, mother was COVID positive, GDM, on medication, hypertension, on Nicardia, IVF conception, had a single umbilical artery with severe oligohydramnios, and the maternal family, unfortunately, the mother's parents, both the parents have died because of COVID, and the mother was on non-invasive ventilatory support for the same. So emergency LSCS was done for premature rupture of membranes, had an extreme premature baby, 27 plus 4, low birth weight, 840 grams, IUGR female, severe RD at birth, was intubated and shifted to the hospital. Surfactant was given, and at that time, at admission itself, this child was noted to have discoloration of the fingers. We thought it was microthrombi secondary to the COVID in the mother, causing a procoagulant or a prothrombotic state. 2-day echo only showed a small PDA, but needed IV paracetamol because of hemodynamic instability. And then the neurosonogram revealed germinal matrix bleed. On day 2, the child was an NIV, and Doppler of the hand we've done was normal, but D-dimers were very much elevated. So we've had a team meeting. We've involved the plastic surgeon and the vascular surgeon as well. And the decision was whether to give anticoagulants for this child, subcutaneous heparin for this child. But given the prematurity, we've all finally decided let's not give any anticoagulations, even though the D-dimers are very, very high, because the risk of a bleed is very high, especially in the first week of life for a 27-weeker. So, but unfortunately, anyway, the COVID fingers have resolved spontaneously, and we got on to CPAP on day 13, HFNC on day 16, nasal prong oxygen on day 50, and then room air on day 53, and discharged on day 58. So these are the numbers of this child. As I've said, the LDH was elevated, the D-dimer was elevated as well, and the ferritin as well, but we just did the conservative management. So these are the fingers that I was talking about. Those are the fingers there. And as you can see here again, those are the fingers. But this is the baby on review. If you can see, the fingers are absolutely normal. And if you can see here on review, this was about a about 3-4 weeks ago, absolutely normal baby with normal fingers. Now, quickly, briefly, 2 more neonates, baby Sravani and Radhika, with severe RD and laryngomalacia. So one neonate with cleft palate presented at birth with shock, biventricular hypertrophy, cardiac dysfunction needing 2 inotropes and seizures, and COVID IgG antibodies were positive in the baby and the mother. And the other neonate presented on day 22 of life with dull activity, stridor, difficulty in breathing. I'll show you the video shortly. Seizure activity, but MRI was normal, had grade 3 laryngomalacia, and epiglottis was all over the glottis, and had a tracheostomy done. And as I said, COVID antibodies were positive both in the mother and the baby. And post-tracheostomy, the baby was absolutely fine, and it's coming for follow-up and it's doing well. So baby was discharged on day 15. The big question was, should we treat or not? Severe distress, severe stridor. So all we did was intubate the child, and then you can see how nicely the stridor is gone, the distress is all gone. Obviously, the reason is because we have been bypassing that area where the child had a obstruction. So on the vent, the baby was extremely comfortable, doing well, saturating well, and everything. So what we've done is we've got a laryngotracheal bronchoscopy done. That's the epiglottis falling all over the glottis. So the ENT surgeon had to lift it up in a big way. And the subglottis is absolutely normal, if you can see. So it was grade 3 laryngomalacia, secondary to the epiglottis falling all over the glottis, and no other structural anomaly. Both the carina and both the bronchi are normal there, as you can see. Now, this child was extubated to CPAP, and this is what you can see. The child distress was there again, was very evident distress and stridor. So we had no option but to have a tracheostomy in place, and this child is absolutely fine following tracheostomy. So these are all the children, and these are the follow-up parameters that we use on discharge, day 5 post-discharge, weekly for 2 weeks, and later for a month. We do CBP, CRP, ESR, D-dimers, ferritin, LDH, tropi, pro-BNP, and 2D echo at 3 months and 6 months on follow-up. And all the neonates that we've been following up, all the inflammatory markers have normalized, and they're showing steady weight gain. And to date, all the neurodevelopmental follow-up for all these children has been good. So this is the flow chart I would like to enumerate. I've got 2 more slides left. This is a flow chart for your neonatal COVID, and the next one is for neonatal MIS-C. So if this child, these neonates would need RT-PCR as well as COVID antibodies, and COVID antibodies being positive, these children, either they're symptomatic or asymptomatic. The asymptomatic children is pretty straightforward. Routine newborn care is what we've practiced. But for the symptomatic children, if the course is consistent with the regular neonatal illnesses, be it RDS, be it meconium aspiration, and if the neonate is improving, we just continue the management as per the regular existing guidelines. But if the neonate is on NIV or invasive ventilatory support, radiological evidence of COVID is there, and there is no improvement despite regular management, that is when we consider steroids in the acute neonatal COVID. Now, if you see the next category, that's the MIS-C. These children have been tested positive for COVID-19 IgG antibodies. IgG antibodies are the ones which get produced from day 10 onwards, day 10 to day 14 onwards, and it could last up to 3 to 6 months or even longer. So, but if the child is asymptomatic or symptomatic, that's what we need to realize first. And as I said, if the child is asymptomatic, all you need is only routine newborn care. But if the child is symptomatic and there is a typical course consistent with the initial diagnosis, all you do is continue the same management like what we did for the acute COVID as well. But if the child has an atypical course, either this child who had a typical and then gradually not getting better, or to start with this child has an atypical course, what we do is check the inflammatory markers and exclude sepsis first. That's the most important thing. And if this neonates have normal markers, we continue with the similar treatment. Absolutely no change. But if these babies have abnormal markers, that's when we have the red alert. And if this child is in shock, if this neonate is in shock, in addition to the regular treatment, what we do is we give IV immunoglobulins, as I've enumerated earlier, and steroids. And if the child does not have shock, we give IV immunoglobulins for sure, and then we debate whether we need to give steroids or not. And one more point here, if there are normal markers also, that means the child is sick, the immunoglobulins are positive, and the child markers, that means inflammatory markers, are normal, but if this child is slowly progressing into MIS-C, then certainly we would treat these children as with shock or not in shock as well. So that's the rough sort of algorithm that we followed in the last 15 months. So I think as a take-home message, we should formulate your own unit guidelines and have a very high index of suspicion during this pandemic. You need to identify the shock and then identify the need for respiratory support ASAP. Very, very important. And we need to identify the neonates, either they have an unusual or an atypical course, especially during this time. We need to do an appropriate and early testing for neonatal COVID and the MIS-C. And as I said, we need to correlate the clinical and lab findings. This is extremely important because we might have a laboratory or inflammatory markers or the IgG being positive, but if the child is stable, clinically doing well, absolutely, I don't think we should do anything to give more IV immunoglobulins or steroids. So it's extremely important that the clinical component is more important than the laboratory component here. And as I said, numbers and clinical decisions, I would go by clinical decisions. And biologicals and basics, I would certainly go with basics rather than biologicals like all the fancy drugs like tocilizumab and itolizumab. So targeted intervention has to be done for effective suppression of the cytokine storm. That is extremely life-saving. And obviously, follow-up is extremely, extremely important.
All right. Thank you very much, Dr. Satish, and thank you, Sankeet and Dr. Anil as well. I will open the floor for discussion and comment and questions. Evangeline is going to help me with taking the live questions. But while we are doing that, I'm going to start by some of the QA came into the board here. So maybe I'll start with Satish. Any thoughts on COVID vaccination for neonatal or for pediatrics? Any thoughts you have? We didn't touch on that, but do you have any thoughts about that?
Yes. See, two things. First is COVID vaccination for mothers and COVID vaccination for neonates. If you see them initially, even WHO has said there's absolutely COVID vaccines are not for pregnant mothers or expectant mothers. That was the recommendation early on. Then they went on to say that yes, vaccination can be given for breastfeeding mothers as well. Then they went a step ahead, and there's a beautiful study that was done in the US. And then they said, yes, you could give it even in the pregnant women. So that is, that was the progression. Now, coming to neonates, until 18 years of age, adults, it has been tried all over the world. Now, the second group is between 12 and 18 years of age. That's being trialed out, even in India. And then the next group is less than 12, 9 to 12. That's the age group. So I think, to answer your question, Dr. Latif, it would be a long way before we even could think about a neonatal vaccination or even pediatrics less than sort of 5 to 10 years of population. It will take a while because first you need to do the trials to see the efficacy, effectiveness, and the safety. Two important things. Effectiveness and safety is good in children between 12 to 18. Then they would go to 5 to 12. Then they would go to 1 year to 5 years, and then only they would go to less than 1 year. So I think this process would take time. So until then, I think we should focus on the basics and the management.
Excellent. Thank you, Dr. Satish. Again, for the audience, if anyone want to comment or want to comment live on any of the questions or any of the answers, please just raise your hand and we can give you the opportunity to talk. The second question, again, this is came in the from the audience, is for Dr. Anil. Anil, there is a question here about do we provide transfusion of blood product in neonatal DIC induced by COVID? So DIC induced by COVID. What about the role of blood product transfusion?
Sir, it depends on the regular indication of blood transfusion in neonate. Like what other indication we have for blood transfusion guidelines, we do follow that irrespective of COVID positive or COVID negative. It doesn't change our decision of blood transfusion, depends on COVID one.
Excellent, thank you. Any other comment?
That's what it is, Latif, isn't it? So that's beautiful. That's the right thing. So there's no new recommendation during the COVID. The same blood transfusion guidelines which we have earlier, whether it's fresh frozen plasma or platelets or packed cells, the guidelines are the same.
Okay, excellent. Thank you. This question for Dr. Sanketh and Satish, for both of you, came from one of the audience, again from the audience. In adult, COVID is associated with worse surgical outcome. How about neonate? That's the first part. What is about the surgical outcome in neonate? And how will we prioritize emergency surgery with COVID-infected babies? And how do we go about that? So maybe we start with that.
Right?
Yes. Yep.
Yeah.
Sanketh, you want to comment about surgical presentation in COVID and outcome?
Yes, it is true that COVID infected patients are having a bad outcome because they can the anesthetists are very jittery on how the patient will respond to anesthesia, because as I hear from anesthetists in the city, the induction of anesthesia is taking a different route, and even the recovery from anesthesia is taking a different route for COVID patients who had affected lungs. So unlikely, but in a pediatric population, overall with our experience and even the experience of other pediatricians in the city, the first hurdle is to operate on a child who is COVID positive. So there's a lot of resistance from the patients and even the caretakers or care providers in some aspects, sometimes. But overall, the anesthetist and surgical team have got a specific set of guidelines on how to manage a COVID positive child in an acute emergency. If it's not an emergency surgery, it's always advisable to postpone to a later date when the incidence and the prevalence of the disease is low in the community. And yes, unlike adults, with the current experience, I could say prioritizing acute life-threatening surgical emergencies should be the first, where the child is critically ill and survival depends absolutely on the surgery. They have to be given the absolute priority first, with keeping in terms of all the available guidelines for safety of the healthcare providers also and the people.
Thank you. Any comments?
That's beautiful. One more point, Latif, there. So that was the thing in especially the GI emergencies. The main pathology, what people think, it's actually the prothrombotic events. So, these hypercoagulable state or the prothrombotic events, they are happening in the, in the gut, in the mesentery. So what's causing is there's ischemic or dead gut. I think that time, as Sanketh was mentioning, we don't have a choice unless we open up and resect. These patients don't live. But fortunately, the children that we've had, the outcomes have been good, Latif.
Excellent, thank you. Last question in the panel here. And again, that's open for everyone from the audience. If you have experience, please comment on this. The question is about COVID in cystic fibrosis baby. I'm not sure the group from India, Satish, Anil and Sanketh, or even from the literature, if you have any comment about this. And after that, if anyone from the audience want to comment about this or anything, please raise your hand.
Because see, this cystic fibrosis, when the guidelines came in first, they said these are the neonates, or these are the children whose premorbid conditions, whether it is nephrotic syndromes or ALLs or neurological disorders. Certainly cystic fibrosis was also on the list. Obviously these children also are on the list, but we have about in my OP follow-up, we have about 6 cystic fibrosis children on follow-up, but fortunately none of them came with an emergency or any other problem. Having said that, see, all the leukemics that had COVID, they all did well, and all the nephrotic syndromes who had COVID, they all did well. Hopefully, they continue to do well.
Okay, thank you. Any comment from anyone of the audience? Have any experience with any of these or any other general comment? If not, I will hand over to Evangeline. Thank you very much. Evangeline, you want to take over?
Yeah, no worries. Thank you so much for all 4 of our guest speakers. I'm sure the live attendees and those that will be watching the recording will find it very, very informative and educational. I think through this presentation, it's important, especially because we're living in pandemic times, to always have COVID-19 at the back of our minds. It can often manifest differently, not necessarily with respiratory symptoms, but also seizures, feeding intolerance and things like that. So thank you so much for sharing your expertise. So I just wanted to give a plug for our next event. So this is our next webinar happening on the 15th of September. And this one's a slightly different webinar in the sense that we're dealing with how to improve our IT and health systems when dealing with pandemic. And we've got 3 wonderful speakers that will be joining us. So we've got Raj Janaparady, who is a business leader for over 2 decades. And we've got David Olmos and Shailendra Kumar. And they will all be sharing their expertise on how we can best keep up in terms of the technological side of things. So I invite every one of us to join, and also send the invitation to anyone that might be interested in this topic. And you can do that by registering for the webinar down below here. And just to, again, tell you a little bit about ourselves. So we are the ANU COVID-19 Peer Support Program. If you would like to learn more about our program, please visit us on this website. Importantly, if you are working in the medical or healthcare professional field and you're interested in volunteering, I'll ask you to email us and we'll get in touch with you. We think it's important to be sharing our knowledge and expertise around, so we really appreciate that. Just before I end tonight's webinar, just wanted to say that especially because we have been talking a lot about babies, so some of us may find this topic quite distressing. So if you require assistance or support, please feel free to contact any of the support services in your local area. So in Australia, we've got facilities like the Lifeline and Beyond Blue, and these are the numbers. And in India, there's also other facilities available as well. Once again, I want to thank all 4 of our speakers. So Professor Mohammed, Dr. Ganta, Dr. Linetti, and Dr. Gupta, thank you so much for spending your time with us in going through all those cases. And I wish the audience well, and thanks for joining tonight.